Thank you so much. Thank you so much for the introduction, and thank you all for attending this session. And I'm going to start the presentation. It's about optimal newborn screening policies for cystic fibrosis. And please feel free to interrupt me and ask all your questions during the presentation. This work was in collaboration with Dr. Ebru Bish and Douglas Bish, and it was in collaboration with the North Carolina State Laboratory of Public Health. Yes. Is there any question? Okay, so I'd like to start my presentation by discussing some background and challenges that motivated this research. So let's just start with disease screening and see what it means. Disease screening is performed to detect a potential disease in individuals who do not have any disease-specific symptoms, but may have the disease. The main goal of disease screening is for early diagnosis of the disease because it can significantly reduce possible risks. It can make the treatment more effective. It can increase the life expectancy of people and reduce the hospitalization costs. And I would like to mention that in many cases, screening tests are not considered as diagnostic tests. And if you want to confirm the existence of the disease, you probably have to go through more diagnostic tests after your screening result was positive. So screening is performed by using biomarkers, but what are biomarkers? Biomarker is a measurable characteristic that is used as an indicator of a disease. Biomarkers are used in the screening process of a wide range of diseases, from cardiovascular disease to autism, diabetes, and different types of cancer. But today's presentation is about using biomarkers in newborn screening for genetic disorders and with a focus on newborn screening for cystic fibrosis. So let's talk a little bit more about newborn screening in the United States. Actually, newborn screening has been a major public health success in the United States, saving lives and preventing disabilities in thousands of babies every year. So each year, millions of babies go through screening tests for a number of diseases, but this number differs among different states. The American College of Medical Genetics recommends a list of 30 genetic disorders, but each state has its own panel. Each state screen newborn for different types of diseases and different numbers of the diseases. But cystic fibrosis is included in the screening panel of all the 50 states in the United States. So now let's focus more on newborn screening for cystic fibrosis. And from now on, I may refer to cystic fibrosis as CF. It's easier. So CF is one of the most common diseases in newborn screening in the United States. As I mentioned before, it is included in the screening panel of all the 50 states in the US. It usually affects lungs and digestive system, and it's a fatal disease, meaning that if you don't treat it, if you don't control it, it can lead to death. The prevalence of CF is approximately 1 in 4,000 newborns in the US. You may think that it's not that high, but CF is an autosomal recessive disease, which means that in order to have the disease, you need to have 2 copies of a CF-causing mutation in your CFTR gene. And if you only have 1 copy of a CF-causing mutation, you are a carrier, which means that you don't have the disease, but you can transfer the mutation to the next generation. And the carrier prevalence rate of CF in the US is 1 in every 31 individual, which is a high number. And currently over 300 known CF-causing mutations are identified. So why is it so important to screen for cystic fibrosis during newborn stages? Because early diagnosis of CF can substantially improve health outcomes. It can improve growth, add years to life expectancy of newborns. It can keep lungs healthy and reduce hospitalization costs. On the other hand, a delayed diagnosis can result in severe malnutrition, lung disease, and even death. So that's why CF newborn screening is universal in the US since 2010. So here is a general scheme for CF newborn screening. So I'm going to talk about each of these tests, the IRT test, genetic test, and sweat chloride test later. But for now, let's take a look at the general scheme. So all newborns have to go to the IRT test. They have to go through the IRT test. If the result of the IRT test is negative, they leave the system. They don't need any further test. If the result is positive, they are sent for a genetic test for cystic fibrosis. Again, if the result of the genetic test is negative, they leave the system. But if the result of the genetic test is also positive, they are sent to sweat chloride test. Sweat chloride test is actually considered as a diagnostic test for CF. If the result is positive, it means that the newborn unfortunately has cystic fibrosis, so they are sent for treatment or consultation. If it's negative, the newborn does not have CF, so they can leave the system. So you may ask that why do we have like multiple stages here? Why newborns have to go through IRT test and a genetic test and sweat chloride test? Why not sending all the newborns to the sweat chloride test at the beginning? So the main reason is cost, of course, because IRT test is relatively very cheap. It's only $1.50 per test. And because all newborns have to go through the first tier test, the IRT test, it's really important that you have a cheap test for the first tier. The genetic test is more expensive. It starts from $18. It can go up to $200, and it really depends on the technology that the laboratories are using. It depends on the number of mutations they're searching for, and many other factors. And the sweat chloride test is approximately $200, but it has many other challenges. In many cases, it needs to be repeated. In many cases, it has some additional cost because not all care centers perform sweat chloride tests. So in many cases, the parents need to drive for a couple of hours to go to a center that performs sweat chloride tests. Looking at this general scheme of cystic fibrosis newborn screening in the US, we really want to reduce the number of unnecessary tests, unnecessary sweat chloride tests or genetic tests, but we also want to make sure that we diagnose all newborns with cystic fibrosis. We don't want to have any missed cases, and that's the big challenge here. So let's talk a little bit about each of these tests first. So we saw that the first test was IRT, or immunoreactive trypsinogen test. IRT is a chemical in the blood, and usually newborns who have cystic fibrosis tend to have higher IRT value. The value of their IRT in their blood is higher than a normal newborn. So the laboratories collect blood samples from newborns on a daily basis, and then they measure the IRT value in their blood. And based on the value of IRT, they classify newborns as IRT positive or IRT negative. So IRT was really cheap. It was $1.50, but it's far from being perfect, meaning that it results in a high number of false positives, newborn who do not actually have the disease, but are IRT positive. They are sent for further tests. And it also has a number of false negatives, newborns who actually have cystic fibrosis, but are classified as IRT negative. And we know that the main goal of screening is for early detection of the disease. So false negatives are something that we really don't want in our screening. So what are the current IRT classification policy? How do we classify newborns based on their IRT value as IRT positive or negative? There are two main classification policies in the United States these days, a fixed IRT value or a fixed daily percentage. So here I listed some examples of both of these classification policies. For example, California has a fixed IRT threshold of 62. It means that all newborns with IRT values above 62 will be classified as IRT positive. They will be sent for further tests. And all newborns with IRT values of less than 62 will be test negative. But this number can be very different from one state to another. For example, in Georgia, this value is 55. In Washington state, the value is 100. And you can see that there is a significant difference between California threshold and Washington's threshold. So for example, one baby with IRT value of 70 is positive in California and IRT negative in Washington. And there is no guideline for the IRT classification policy. There's no national guideline that says that this should be the IRT value. For percentage-based policy, again, we have different numbers. North Carolina uses top 4%, New York uses top 5%. So what these states do, they measure the IRT value of all newborns in a day, and then they sort them and they classify the first top 4% or 5% as positive and all others as negative. The main reason they use a percentage, not a fixed value, is that there are some environmental factors, for example, the humidity or temperature, that can affect the IRT value. And using a percentage rather than a fixed number is because they want to take care of these environmental factors. But again, there's no guideline that says which policy is better and what numbers should be used. For genetic tests, there are two main groups of tests. You can use a mutation panel, or MP, or you can use a genetic sequencing. A mutation panel is more expensive than IRT test. You basically search for a subset of the CF causing mutations, the known CF causing mutations. But again, there is no guideline here. The American College of Medical Genetics recommends a panel of 23 mutations, but North Carolina and Wisconsin use a panel of 139 mutations. And again, look at the differences here, 23 versus 139. New York uses a panel of 39 mutations. California uses a panel of 40 mutations. And you can see that the number of mutations can be really different from one state to another. The types of mutations are also very different. And there's no national guideline that says what mutation panel you should use and what number of mutations and what type of mutations. The second genetic tests are genetic sequencing that sequences the entire CFTR gene and look for the known CF causing mutations, but it's more expensive than mutation panel. And usually it's not very efficient to perform it on a large number of newborns. Okay, is the sweat chloride test, which is a diagnostic test. It's the most reliable way to diagnose CF, but it's expensive and it has some other difficulties. For example, it needs to be performed between 10 days to 4 weeks. To 4 weeks after birth. So the period is very short, and it needs parents, sometimes it needs parents to take the newborn to a care center. So that's another difficulty. In many cases, it needs to be repeated because they need to collect a specific amount of sweat, and it's not easy to collect it on newborns. So in many cases, it needs to be repeated over and over, and it usually causes parental distress. So it's a reliable test, but it has its own difficulties. So looking again at the general scheme for CF newborn screening, so hopefully now you have a better idea about each of these tests. So for all of these tests, you've observed that there is no national guideline, and there's room for improvement for IRT tests, for genetic tests, and for the entire for the general scheme. But for today's talk, we are going to only focus on the IRT test and try to see what is the optimal IRT threshold policy. Is a fixed threshold policy better than a fixed percentage, or we have to come up, or a fixed percentage better, or we have to come up with a totally new policy. So this is the focus of today's talk. So let's see. So the IRT test, again, you measure IRT in the blood, and based on that, you want to classify newborns as positive or negative. There are many different factors that can affect the IRT level in the blood. There are some external factors, for example, temperature or humidity. For example, low temperature tends to increase the IRT reading of newborns. If you look at the average IRT value of newborn during winter months and summer months, you see that during winter months, the average IRT value is significantly higher than summer months. So that is something that is really important, and it needs to be taken into account in newborn screening. And there are also some newborn specific factors such as birth weight, race, or gender that can affect the IRT value of newborns. For example, African American newborns have significantly higher IRT readings than other races. So to summarize our findings, so these findings are from the 5-year data sets that we received from the North Carolina State Laboratory of Public Health. And then we figured out that we kind of listed all the important factors that can influence the IRT level. These factors are seasonality, Again, as I mentioned before, during winter months, the IRT value is higher than summer months. Race of the newborn, birth weight of the newborn, and gender. We also observed that CF prevalence rate is significantly different among different races. And all of these factors need to be considered, we do need to take them into account in our screening policy, which is not the case in the current screening policies. So here, this is a summary of the data set that we received. So we have different races, the CF prevalence rate for each race, the average IRT value, the total number of newborns from each race, the total number that are sent to mutation panel, sweat chloride test, and the total positive cases that we found. So if you only look at the first two rows, the Caucasian and African American, you can see that African American newborns have significantly higher IRT values, but they have significantly lower CF prevalence rate. It's 1 in 21,000 compared with Caucasians at 1 in 3,700. So there is a big difference. And if you do not take into account all of these factors, the fact that the CF prevalence rate is different among races, and the fact that the IRT value is different among races, which is the current case in the US, you unnecessarily send a large number of African-American newborns to the next tier to genetic tests and sweat chloride test, while they have a really low CF prevalence rate. So this, first of all, it creates unnecessarily parental distress for African-American babies and for their parents, and it prevents newborns from other high-risk populations to go for further tests. So this is really important, and we do need to take that into account. So this is what we did. I do not go into details of the model, but I want to give you a general idea about how we modeled this and what we did. So we said that every day we have a set omega. It's a set of subjects received for screening, the blood samples of newborns for screening. And then we have two groups of, let me know if you have any questions. Okay, and then we have two groups of variables. We have unobservable variables. So we have YJ. This is the actual biomarker level of subject J. Why do we say it's unobservable? Because there are some factors that can affect the IRT value of newborns. So we assume that the actual IRT value is unobservable. And what we observed, what we measure is the IRT value and all other perturbations, everything that affected the IRT value. And then we have the disease risk, PJYJ, disease risk of subject J, and this is unobservable as well. On the observable side, we can measure the IRT value of newborns, that's YJ tilde. And then we have a vector of the IRT value of the measured IRT value of all newborns in one day. And we care about this vector because there are some environmental factors that can affect all newborns, the IRT value of all newborns in one day. So it means that the IRT values may be correlated. For example, if one day the weather is really cold, the IRT value of all newborns tend to be higher. So that's why we need the entire vector to make decisions. And then we have theta J. It's a set of specific attributes for subject J, such as like birth weight, gender, and other things, race, and other things. And then we have a theta vector, that's the subject attribute vector. And DJ, the positivity status of subject J, follows a Bernoulli distribution with probability PJ, YJ. So to summarize, every day you have a set of IRT values. You have a vector of all IRT values of all newborns in that day, and you know the vector of all the attributes of all the newborns. And then we define a biomarker estimation function H. H can be a general function. And then by applying function H on these two variables, we can find a point estimate for the actual biomarker level, for the actual IRT level of subject J. And then from there, we apply a risk estimation function G on this point estimate, and then find out probability, the disease risk for subject J. So the decision problem is how to classify all the newborns in set omega as test positive or test negative based on their biomarker measurement and all other factors to minimize the total misclassification cost. And we also want to keep in mind that the data is noisy. These measurements are noisy and they might be correlated. So we came up with two main models. We have our model one, problem EM, is to minimize the expected misclassification cost. The misclassification cost is the cost of false negative and the cost of false positive. And the second model is to minimize the maximum regret, problem RM, where regret is the cost of not acting optimally. So we have these two main models. And then based on the results, so we solved these models and characterized the optimal solutions, and we found really interesting results. We found that in both models, the expectation-based and the regret, the minimax regret-based model, the threshold policy, the optimal threshold policy, is a risk-based policy, which means that instead of having a fixed threshold on IRT level, or instead of having a fixed percentage, you need to have a fixed threshold on the risk of the disease. And this threshold only depends on the cost of false positive and cost of false negative. And then you estimate the risk of the disease for all subjects in the set and compare that with your risk threshold. So this is the result for problem EM. For the problem RM, the regression-based problem, this is very similar. The threshold is the same, but here, instead of comparing the point estimate of the risk, we compare the average of lower and upper bound of the risk with the threshold. So again, to summarize, this shows that the optimal policy is a risk-based policy, a risk-based threshold policy, which means that the current policies, the fixed value and fixed percentages, cannot be optimal in any case. So there is no fixed IRT value that can be optimal, or there is no fixed percentage that can be optimal. And that's the main result here. So the main reason that the current IRT classification policies cannot be optimal is because they fail to take into account external factors and subject-specific characteristics. Because if you define only one specific value for IRT, you do not take into account that different races have different average IRT values, that race has a significant impact on CF prevalence rate and many other things. So these are the results for the validation data set that is approximately for 2 years from the North Carolina State Laboratory of Public Health. So here we listed many current IRT classification policies. So we have a fixed policy of 100, a fixed policy of 62, a fixed policy of 55. And then we have a fixed percentage of 5%, 4%. And the last two rows are our proposed policies, the expectation-based model and the robust model. And then we calculated the total cost of false negative and false positive results. And then the total number of false negatives, false positives, sensitivity, and specificity. One thing to mention, so here, instead of estimating cost of false negative and cost of false positive separately, what we did was to consider the ratio of cost of false negative and false positive, and then we performed sensitivity analysis on this ratio. So K is cost of false negative divided by cost of false positive. For this table, K is equal to 4,000. If you're interested in calculating the actual saving by using our proposed methods, you can multiply the difference of the cost by 68.74. This is from literature. This is an estimation for the cost of false positives. And you can see that we can save a lot by using our proposed methods, the EM method or RM method. You can see that the total expected cost is lowest for our proposed models. And then North Carolina currently uses a fixed percentage of 4%. So they're currently, based on our results, their total expected cost is approximately 20,000, but they can decrease it to approximately 16,000. Multiplied by 68.74. So that's a big difference. And you can see that our proposed policies can outperform all the current policies. And here we perform sensitivity analysis on the value of K. So here we have value of K. Again, K is the ratio of cost of false negative and cost of false positive. We changed the value of K from 1,000 to 10,000. And then These two lines are our EM and RM policies, and all other points are fixed percentage policies or fixed values. And we tried a wide range of percentages and values. So from 1.5% to 6%, a wide range of values from 45 to 65. And you can see that our proposed policies, because it takes into account many different factors that can affect the IRT value, it outperforms all possible fixed percentages or fixed value IRT policies. So for a specific sensitivity, it always results in better specificity. For a specific specificity, it always results in better sensitivity. So to summarize, our proposed policies, both expectation-based and robust policy, they minimize the expectation misclassification and the maximum regret cost. These are the optimal classification policies for IRT test under uncertainty. They can take into account biomarker perturbations. They can take into account all factors that can influence the biomarker or the IRT value in CF newborn screening case. And this is really important. And a really nice thing about our proposed policies is that they are easily implementable. Laboratories already have all of the measurements, and they don't need to collect any more data. They already have everything we need. They just need to apply these methods to classify the newborns as positive or negative. And then some current and future research directions for this study is, again, I'm currently working on optimal mutation panel, because you observe that for genetic tests, the number of mutations and the type of mutations that each state uses is really different. And the mutations are actually very different among races. In some races, some mutations are more common. In other races, some mutations, other mutations are more common. And it's really important in order to have an equitable and accurate panel. It's really important to take into account these differences into our screening policies. So I'm currently working on that part. The next step would be to look at the entire CF newborn screening scheme and try to make that optimal, because nowadays with all the improvements in genetic test results, the cost is a little bit lower. So I'm thinking about trying to figure out if it's better to skip the IRT test, start from the genetic test, or it's still better to start with IRT test and then only send IRT positives to genetic tests. So that's a really interesting topic as well. And the application of these proposed methods are not limited to cystic fibrosis. It can be applied for screening for all genetic diseases, or even for like other diseases such as Alzheimer's disease, diabetes, autism, or different types of cancer. So this is my main area of research. I'm really passionate about this research, but I'm also working on some other research areas. I'm working on subsidy management in healthcare systems. So in many countries, we have both public and private healthcare systems. So what should be the subsidy level to have a more balanced system? I'm also, during COVID-19, I started working on food insecurity. And it's actually really interesting to see how food insecurity increased after COVID-19 and how the gap between different races increased. And if you're interested in operations research, there is lots of room for improvement here. There is lots of room that you can contribute to these types of research. And I'm also interested in the impact of mental health and nutritional habits and lifestyle, how your nutritional habit and lifestyle can impact your mental well-being. And I'm also working on that. I think that's all I had for today. So I would love to answer any questions. If there's any, you can always send me an email if you have any questions, comments, or I don't know. Is there any question?